In this video, one of America's top heart surgeons, Dr. Phillip Ovadia, shares expert insights on heart disease, heart health, and what really causes it.
Tell everyone a little bit about yourself that got you into this space. What was the trigger that says, Ovadia, change?
Yeah, it really was kind of what you talked about, right? That realization that I was headed for my own operating table. And it was also that desperation that, that the advice that I was taught to give, that I know you were taught to give, right? Seeing it not working for myself, for my patients. It just kind of came to that crisis point that I said, we have to be able to do better than this, right? I wanted to do better for myself. I wanted to demonstrate better for my family, for my children, and I wanted to do better for my patients. And so that was really what I think set the stage for me to be open to the new information. And you know how it is, right? When you open yourself up to the universe and you're open to hearing these new ideas, I think they find you, right? And for me, that event occurred while, ironically enough, I was at a Society of Thoracic Surgeons meeting, right? And I'm there expecting to do the usual thing, right? Learn how to do surgery better, learn about the new techniques. Coincidentally, or maybe not, one of the guest lecturers that was invited that year was Gary Taubes. And this was right when Gary had written The Case Against Sugar. And of course, prior to that, he had written Why We Get Fat and Good Calories, Bad Calories. Listening to Gary really opened my mind, right? And his concept of talking about the types of food that we eat being more important than the amount of food that we eat. This is what started my journey. And, I went on a low carb diet, eliminated sugar, like you said, was able to lose 100 pounds. And along the way, what I came to realize was that this is what my patients needed to know as well. This is what could help them. And ultimately, I came to the realization that the patients that end up on my operating table, they are all failures. But it's not that the patient failed, it's that the medical system failed that patient. That we allowed a patient to get to the point that they need open heart surgery for what is really a totally preventable disease. Heart disease, in my mind today, is a preventable disease. And when we don't give the patient the tools to prevent that disease, we fail that patient. And so that, is the change in my thinking now. And I know that we can do better by these patients. And that's what drives me today.
You've been doing this a long time, and cardiovascular disease is still the number one killer of all of us.
Mm-hmm.
And it's happening, it seems, younger and younger. And there seemed to be an up spike in the incidence of heart disease in the turn of the 1900s through the up to 2000, and still today it's very high. What did you learn from Gary Taubes and others that seemed to be the kicker that got us here?
Yeah, and great questions to be asking. And just to kind of drill in on this, right? I go back to when I was doing my surgical residency, and I was doing a training program in general surgery. And, it came time to decide if you're going to subspecialize. And I decided, I wanted to go into heart surgery. I found it technically interesting. The physiology, behind it is fascinating. And so I decided I wanted to go into heart surgery. And my mentors at the time, my professors, told me that was a ridiculous idea because they said there's going to be nothing left for you to do in 20 years. This is the late 1990s, early 2000s. Statins are the most widely prescribed class of medication by that time. And the general consensus was, we fixed heart disease, right? We figured out the problem. We have these medications, and a heart disease is going to be eliminated. And, here we are 25 years later, right? Heart disease is still far and away the number one killer and worsening, despite that optimism about it. So, what I now have had my eyes open to, right, and what I've learned over the past decade or so while doing this approach, right, is that first and foremost, we must have something wrong about what we thought was causing heart disease. Because if it was cholesterol primarily or cholesterol only, as oftentimes the medical system today looks at it, then heart disease should be largely gone, right? Because we have these medications that effectively lower people's cholesterol. And we've been giving this dietary advice, right, to eat low-fat diets now for the past 40 plus years. And the evidence shows that people are largely following that advice and people's cholesterol levels are lower than they've ever been. And yet heart disease is getting worse. So I think anyone logical, needs to looks at that and says, we must have something wrong about that underlying assumption about cholesterol. And that really is the big one, right? It leads you down other pathways, but that's the big one that we need to address.
Is there something about our modern diet? I mean, the recommended diet is plant-based, Mediterranean, 3 to 6 meals a day, lots of exercise, and that lifestyle that I know that I led. And I was never really heavy, but I was beginning to I had migraines since a kid, arthritis, psoriasis, bowel bleeding, kidney stones, ADHD as a kid. I couldn't read. My father had a quintuplet bypass in his early 70s, and he lived to 94 almost. And I'm sure he had hypertension and all those things, and he was never really that active later on. And is it something that I need to be concerned about, or do you think this lifestyle we're talking about is something that can help me and others reduce their risk of it happening to us?
Yeah, so I think the answer is both. Yes, you have reason to be concerned, rightly, but the lifestyle that you've chosen and that we talk so much about, I do believe is the best way to minimize the chances of suffering that same fate. And I think it's something that we can't just assume that this lifestyle, this diet, low carb carnivore diets are going to fix the problem, but it does give us the best chance. And in conjunction with that, we should be actively kind of surveilling for heart disease, and we should be measuring how much heart disease do we actually have, right? And that's a key clarification or a key differentiator, right? It's not about measuring your cholesterol level and thinking that predicts your risk of heart disease. It's about measuring the actual heart disease. And we have ways to do that. And we should be utilizing those tools to do that because that is really going to give us the information that we need to determine, okay, is this diet that I'm eating helping the problem or not? And, other components of my lifestyle, right? Are they helping or not? And that's something, again, that we don't do a great job of in medicine. We treat the disease when it occurs. When you have the heart attack, when you have the symptoms of heart disease, we start paying attention to it. And, in addition to the different paradigm around diet that I talk about, I also talk about this different paradigm about screening for heart disease, which is something we can actually effectively do these days.
And so family history on my side, obviously. Yep. And although my grandmother lived 104, my parents lived to 94, and they were not particularly active. They ate a Mediterranean diet, and I thought I was very did a lot of exercise, ate a healthy diet. Yet when I look back to my father, and now I was gifted a CAC score back a year ago. I would have never gotten it myself. Is it a good start for people looking for their risk of heart disease?
Yeah, I think the CAC score is probably the best way to start figuring out your heart disease risk and your heart disease status. It's more than just risk. It's how much heart disease do you actually have today? And that's part of understanding what your risk is moving forward. And the CAC scan, so for people to set the basics, right? Coronary artery calcium scan. It is a CT scan. And so anyone that's had, CT scans are fairly ubiquitous in medicine these days, but they're simple tests to do. They're not invasive, right? You just lay down on the scanner
Mhm.
and you get the scan done. The CAC scan in particular, you don't need to have an IV put in, so completely non-invasive. Literally takes about 3 to 5 minutes to do the scan. And in most locations here in the US, it's going to cost you $100 or less. It's great that you got gifted that, right? And you were probably thinking, oh man, this is such an expensive test. Someone really went out of their way. Turns out that it's not that expensive a test, but it's such a valuable test. Like when I look at the value that we get from tests in medicine today, I think it is hard to find another test that beats the CAC in terms of being low cost, but such high value information that we get from it. And, it shows us heart disease. Now, it has its limitations, right? What we specifically see on that scan is whether or not there is calcified plaque in the arteries of your heart.
Hmm.
Now, calcified plaque is only one type of plaque that occurs. So we're not getting the complete information, but it's a pretty good screening test because if you don't have any calcified plaque, if your CAC score is 0, it is highly unlikely that you have significant disease today or are going to develop significant disease over the next few years. It's not a lifetime guarantee, but it at least is a pretty good guarantee in the next, let's say 5, maybe 10 years, that your risk of having a clinical event like a heart attack is pretty low. If it's not 0, right? It's then a sliding scale. And the higher the number, right, the more concern you should have about how much disease you have today and how likely you are to develop disease in the future. And so that then is going to lead you to maybe some additional testing and also to be thinking about what can I do to stop this from getting worse. And that's why I think the CAC scan is so powerful because it gives you all that information and it kind of starts to guide you towards, okay, now what can I do to stop this heart disease from getting worse?
Drum roll, please. So this was done about a year ago, and my CAC score was 682, placing me in the 70th percentile. And I don't know if the LAD was 488, left main coronary artery 57, circumflex coronary 5, right coronary artery 48, and the ramus branch 104. Total calcium score 468. And for some reason, it had where was that six? The total coronary artery calcium score was 682, and then there's another one that says 468 on the second one. So I followed up with the CT angiogram,
Yep.
and this is the first time I've shared it with Dr. Ovadia. And let's see
And maybe before you give that, Rob,
yeah,
let's just unpack the CAC score a little bit, right? So
please, yep.
a score of 687, and they said you're in the 70th percentile, right? And those are the kind of two numbers that most people are going to pull out of their report. What is your total score? So it's called the Agatston score after Dr. Agatston that developed this. And it's basically, you can think of it as the volume of plaque that you have and the density of the plaque that you have. And you're kind of, multiplying those to get a score. And this score can be, again, you start with a 0. The highest score I've ever seen is about 7,000. So it gives you an idea about the range there. And, then they tell you your percentile. So what that means is compared to people that are about your age and the same sex, right? So male and females have different kind of plaque levels typically. So in your case, right, it said you're the 70th percentile. So that means for men that are about your age, you have more plaque than 70% of them. 30% are going to have more plaque than you. And it tells you, okay, so you have a higher than average score on this, at least. And, you can use that to start to figure out, okay, what is my risk of disease over the next few years? And for people that are really interested in this, there's something called the MESA calculator, MESA. And you can go and you can put that in and go to the site, and you put in your calcium score and you put in a few other factors like your age, your blood pressure, and your lipids. And it will tell you what your risk of having a heart attack is over the next 5 to 10 years. So that's how we start to use this score. Now, when you get scores that are above, some people say 200, some people say 400. But at some point you start to worry about, okay, do you actually have a blockage in your artery that is putting you at risk for a heart attack imminently, that is reducing the amount of blood flow that is going through that artery and threatening the muscle, right? That's what these arteries are supplying, is the actual muscle of the heart. So is that putting you at risk for a heart attack? And that's where we now need to get the further detail. And that's what the CT angiogram is. It's a more advanced type of scan. Logistically, the difference is they put an IV in your arm now, and they give you some dye through that IV. And by seeing that dye go through these arteries now, we can get more detailed pictures. We can see the calcified plaque, but we can also see the non-calcified plaque. And we can now start to measure how narrowed a blood vessel might be. So that's the additional information that we get from the CT angiogram. And now we can unveil what Dr. Rob's results are.
Well, interesting. So now about 2 years ago, I had calcific tendonitis in my right shoulder. I couldn't move it.
Mm-hmm.
The x-ray the doc did, he said, you have more calcium deposits in your muscles than I've ever seen before, all over the place. I don't know if that's an important point to all of this anyway, but that was kind of an interesting thing that I found. Now, the next thing I did, and I don't have the results other than I did a treadmill echo test. What do we call that?
Yeah, stress test, we call it.
Echo stress test. Right. And he said, you're fine. I passed it with flying colors. All right. And then I said, well, is there anything else I can do? And that's where the CT angiogram came in as the next step. And the rereading of the total calcium score was now 724. The coronary arteries arise in normal position. There is right coronary artery dominance. The left main coronary artery is patent with no evidence of plaque or stenosis. The LAD artery is patent. There is diffuse calcified and non-calcified plaque proximally, which appears to narrow the lumen less than 50%. It gives off one small patent diagonal branch. The LCX, or the left circumflex artery, is patent. No diffuse calcified plaque in the mid circumflex, narrowing the lumen by about 50 to 75%. I don't know if that makes sense. There is, maybe it should say, there is diffuse calcified.
Yeah.
Is in the mid circumflex, narrowing the lumen by about 50 to 75%. It gives off one patent bifurcating obtuse marginal branch. There is dense calcified plaque at the bifurcation. The degree of calcification is such that any degree of luminal narrowing cannot be estimated. Cardiac valves, there's no thickening, calcification, or calcifications in the aortic or mitral valves, none. Pericardium contour is preserved with no effusion, thickening, or calcifications. So calcified plaque in all three coronary arteries with at least moderate luminal narrowing seen in the circumflex. And I think there was one other thing here. Let's see. I think there was mild aortic. Where did I see that? There was a little aortic, ascending aortic enlargement.
Okay.
Mild, and that was it. I have some other numbers. Would you like to hear some numbers? Or do you want to go off on that first?
Yeah, so I think what that information is good information. So what we're trying to determine here, like I said, there's two factors that come into play here. We have the physical structural narrowing of the blood vessel, right? So you picture the blood vessel as the pipe, and this plaque is building up, usually first at the edges of the pipe. And, over time, it starts to make that lumen that the blood is flowing through smaller and smaller.
Mm-hmm.
And so we have that physical measurement, right? In one blood vessel, they said it's maybe 25 to 50%. In one of the other blood vessels, they said it's 50 to 75%. And that's one piece of information that we need to know. Now, the other piece of information is, what is the physiologic consequence of that narrowing? In other words, again, the purpose of these blood vessels is to deliver oxygen to the muscle of the heart. And the heart muscle needs that oxygen to be able to do its work, right? Pump. At what point does the blood vessel become so narrowed that the muscle is not getting adequate oxygen? That's when we get into trouble. That's when we start having symptoms like angina, people talk about, chest pains, or that's when we have a heart attack if that oxygen supply is reduced enough. So we actually can combine the two pieces of information that you talked about. The CT angiogram tells us 50 to 75% narrowing, 25 to 50% narrowing in different areas. And the stress test that you mentioned having tells us what the stress test is actually measuring is there adequate blood flow getting to your muscle? So the stress test looked okay, meaning that you have adequate blood flow getting to the muscle.
Mm-hmm.
And the CT angiogram tells us, but there's plaque there, right? And some of it is a fair amount of plaque and is reducing that blood vessel by 50 to 75%. And so the information to take away from this is, okay, you're not at imminent risk of having a heart attack. You're getting good blood flow. And we now need to make sure that this plaque doesn't continue to accumulate. Because if that 50 to 75% blockage goes up to, let's say, a 80 to 90% blockage, that is likely, that may cause you trouble, and that may cause that reduction in oxygen delivery. And that's when, something needs to be done about it. But if you can stop it from getting worse, and, we'll talk about what things we might want to think about to stop it from getting worse, and it stays at this same level, there's no reason to think that you shouldn't be fine for the next, many, many years, and that you can follow your parents and your grandparents and live a nice, long, healthy life.
So now I do have some other tests here that I've done just kind of through the years. I've always had elevated cholesterol.
Mm-hmm.
And interesting, in general, my hemoglobin A1C has always been below 5.6, but at the time of this test, it was 5.8. I don't know if that's relevant, but my cholesterol level back in early January of last year was 405. The LDL cholesterol was 328. My glucose was 66. Prior glucose was 52. So I tend to have low glucose levels.
Mm-hmm.
And I've done insulin levels. I didn't have it, which are typically low. And let's see, I have a folic acid of 2.1, which is considered low. My homocysteine 14.7 in normal range. Lipoprotein A 14.8. Iron normal. Uric acid normal. Vitamin B was 12, was mid range. Insulin was 2. Ferritin 407. C-reactive protein was less than 1. It typically has been less than 1 on other draws. LDLP 1598, so that was in a borderline high range. HDLP was low at 23.8. And
You have
thyroid.
a small LDLP there?
I have a small LDLP was 153.
Okay, great.
And it's in the lower range of normal.
So we start to look at, right, again, we want to start to look at what are the factors that lead to plaque and lead to, ongoing plaque progression. And inflammation, insulin resistance, and having the poor quality cholesterol is the way that I think about it, right? It's not about the total amount of cholesterol per se. It's what is the quality of your cholesterol particles to determine, are they potentially problematic? So on the insulin, and insulin resistance front, right? You mentioned low glucose, low insulin level, and that, that's good. That's what you want. You want to live in a low glucose, low insulin environment for the majority of your life. And that is going to be powerful in preventing against heart disease. Now, the problem that comes up, right? And oftentimes I have people like yourself, right? They've been doing low carb carnivore diets for a while, and then they get their first scan, their first CAC scan, and the score isn't 0, right? And it's like, okay, when did this plaque accumulate? Did it accumulate recently when I've been doing low carb carnivore diets, or did it accumulate before I started that? And, for many people, right, they were insulin resistant, likely, and they had high glucoses, likely, but, they may not know that because they weren't really testing it back then, or maybe they were. But, it's more likely the plaque accumulated then than during, when you go low carb carnivore and the insulin resistance and the inflammation resolves. So, your part of the puzzle then becomes, okay, what's happening to your plaque over time now? And for someone like yourself, right, I would repeat typically a calcium score, or maybe even the CT angiogram, a year later, let's say, or 6 months later. And is there new plaque forming or not? That's what we now want to know, sort of moving forward. And if we've addressed the right factors, insulin resistance, inflammation, got in a good quality of our cholesterol, then that usually is going to translate to the plaque won't be progressing. And we just have to deal with the fact that, you accumulated plaque for the number of years that you weren't doing this stuff. And maybe there are other factors going on, right? You mentioned, a lot of calcium in your muscles. So maybe you're just prone to, you have a lot of extra calcium, and we got to figure out how to get that out of your body, or how to prevent that from worsening. Maybe there are non-dietary environmental factors, and I point people towards this often. And I think we're increasingly recognizing that, for instance, you can have a perfect diet, But if you're living in a mold infected home, and many of us are and don't know it, unfortunately, that might cause a problem. If you're getting exposed to heavy metals in your water, or perhaps, other environmental sources, that can cause trouble. And it may not show up in the traditional testing, but it can be an unrecognized problem. A fair number of people I deal with have periodontal disease that they may not know about, right? This could be something like an old root canal that's kind of chronically infected and they don't know about it. This can also, again, the heavy metals from metal fillings, right, can contribute to heart disease. And so it's a bit of a detective work, right? You gotta keep digging deeper until you figure out what are some of these factors that might be driving the ongoing heart disease if it's continuing to get worse, right? Someone like yourself now who, okay, we know what you have. We don't know when that occurred. We know that your other numbers are now looking pretty good, right? You don't have insulin resistance. You don't have inflammation. The quality of your cholesterol particles look good. And so, I would probably say we could sit tight and we could get another scan in 6 months to a year, and we can see, is there more plaque accumulating or not? And if there isn't more plaque accumulating, then we should be pretty good. If there is, like I said, we got to keep kind of, digging another layer deeper and saying, okay, is there something else going on that we haven't identified that's driving this plaque formation?